Well, greetings everyone, and welcome to the EKG case for the week of June 30th, 2014. Before we get started, I actually wanted to put a plug in for two educational programs that are going to focus quite a bit on electrocardiography that I happen to have the fortune to be involved in. One of them is a Mediterranean cruise. For those of you that might want to go cruising with cardiograms, check out www.ekg or ecgcruise.com. The cruise is going to be September 14th through 21st, and during 2 of the days at sea, we're going to spend time talking about electrocardiography, have some workshops. All the rest of the time is going to be fun, but it's a nice chance to write off a trip. And this is sponsored by Florida Emergency Physicians. It's a fantastic group of emergency physicians that run in residency down in Orlando, and I've worked with them for probably about 10 or 12 years now running EKG courses, and this year we decided to do something a little bit different. So I hope some of you can join us out there. It should be a lot of fun. And if you don't want to go that far, we're going to be holding a course in Las Vegas. For a number of years, I've been able to work with some folks from up in Boston who created an emergency cardiology course called the Heart Course. This was originally kind of a spin-off of Ron Wall's Airway course, but now it's off on its own. And they've been running this course for a number of years in Las Vegas for most of the years. And this year, October 2nd through 5th, the course is going to be coming back once again. And on October 2nd, we are going to have an EKG pre-conference. It's going to be from about 4 p.m. to 7 p.m. But the overall course is really, really great. So if you prefer to go to Las Vegas for some EKGs, that's a great place also for a lot of things, including electrocardiography. Well, somewhere between Las Vegas and the Mediterranean is a wonderful city called Dublin, Ireland. Well, maybe my geography is not all that great. It's not exactly between Las Vegas and the Mediterranean, but kind of-ish. Anyway, in Dublin is an emergency physician by the name of Andy Neal, who I've known via Twitter for quite some time. And those of you that are foam and Twitter fans will probably know Andy. He sends out a lot of great tweets and is fairly well known. He's got a lot of followers on Twitter, and this is a case that he sent me recently. He sent me a couple of cases over the years, and this is a really great case. He was taking care, or actually one of his colleagues was taking care of a young woman who presented with some chest tightness, and Andy got involved in the case as well. Now, this young woman had a history of prior palpitations, but really had not had a prior workup or any previous EKGs. I guess out in Ireland they call them ECG, so no prior ECGs. She was awake and alert. Her heart rate was irregular and varying from the 170, sometimes faster, sometimes a little slower. Blood pressure can't be better than 120/80. She was lucid, no signs of acute cardiac instability, normal mental status exam. Otherwise, okay, get a 12-lead EKG, and this is what Andy and his colleagues saw. So first thing you'll notice is that the rhythm is irregularly irregular. So if we're going to label this with the diagnosis, we can probably start out by saying this is atrial fibrillation. There's a few other things that give you irregular rhythms, multifocal atrial tachycardia and atrial flutter with variable conduction, but this certainly doesn't look like flutter and it doesn't look like MAT. So we'll start out by just calling this atrial fibrillation. Now you'll notice that maybe the overall rate, when you average everything together, is in the 170s, but in some places let me get rid of this. In some places it's a little bit slower, but in some places it's really, really fast. In some areas this is approaching 250, 300 beats per minute, and there's some importance to that in terms of the diagnosis. We'll talk about that. You'll also notice that a lot of the QRS complexes are wide. So when you see wide QRS complexes, you think about the differential for wide QRS complexes. That's the way I approach the EKGs. I stop and think about differentials. So we've got atrial fibrillation. Now let's talk about the differential for a wide QRS. Well, left and right bundle branch block pattern can certainly give you a wide QRS. Paced beats, anytime you say bundle branch block, you have to include pacers also, because pacers mimic bundle branch block. So pacers will give you a wide QRS. Toxicities, especially sodium channel blockers, tricyclics, other such things can give you a wide QRS. hyperkalemia, the syphilis of electrocardiography. Hyperkalemia can do anything to the EKG, and it certainly will widen that QRS if it's bad hyperkalemia. Wolff-Parkinson-White will widen the QRS, and then if you've got a wide QRS and you've gone through this and you haven't come up with any of these diagnoses, then kind of a wastebasket term is interventricular conduction delay. If you don't have a good reason for wide QRS, it tends to be referred to as just a non-specific interventricular conduction delay. Left ventricular hypertrophy is one of the types of interventricular conduction delay, and essentially it's just a wide QRS and you don't have a better explanation for it. And LVH oftentimes is one of those things that we would say produces a wide QRS, and we say it's just because of this non-specific interventricular conduction delay. So let's take a look at our differential here. First of all, you notice that this is not a classic left bundle branch block pattern. There's no deep S wave in V1, V2, V3, and it's also not a classic right bundle branch block pattern. It does have a little bit of a rabbit ear pattern up here, but typically right bundle branch block pattern tends to be very uniform in morphology, and the QRS complexes are really changing quite a bit. So tell you what, let's go to this and let's get rid of bundle branch block pattern. There's also no paced beats up here, so we can get no pacer spikes, right? So let's get rid of pacemaker. And there's nothing in the history that I'm giving you suggesting that this is a sodium channel blocker overdose. Sodium channel blockers typically give you a rightward axis and a tall R wave in AVR. And, well, we are kind of seeing that. Wide QRS, we are kind of seeing that. So, well, I didn't give you anything in the history suggesting that, but tell you what, just to be fair, we'll put a question mark there. And if we go back and get more history of an overdose or toxicity, then we should strongly consider that. Hyperkalemia. You've always got to consider hyperkalemia. Hyperkalemia probably would give you a somewhat slower rate than this. This is really fast for hyperK. You also don't really notice any classically peaked T waves. So, well, I'm going to go back and cross off hyperkalemia. WPW. Is there evidence of WPW? Well, that's another thing that we've got to consider. And we'll talk about why we've got to consider Wolff-Parkinson-White syndrome. And then if you've got an answer, then you just simply don't call it interventricular conduction delay. Again, this is a diagnosis of exclusion. So going back and taking a history, I'm going to take a little license here and just cross this off because there's nothing in the history, it turns out, suggesting tox. And that leaves WPW. Is this AFib with WPW? Some of you already know the answer, but that's exactly what this is. Atrial fibrillation with WPW. And for those people that didn't know, well, we're going to quickly review why this is AFib with WPW. There's some very important characteristics that you'll typically find when a patient has AFib and WPW. Now, this is what is happening inside the heart when a person has AFib WPW. Remember the atrium, with atrial fibrillation, the atrium's beating 300, 400, 500 times per minute. Some of the impulses are going down the normal pathway, producing narrow QRS complexes. Some of the impulses are going down the accessory pathway, producing myocyte to myocyte conduction, which is very inefficient, so you get wide QRS complexes. And then some of these impulses are fusing and producing QRS complexes that look somewhere in between. And the overall resulting rhythm then is a rhythm that has some morphologies that change considerably. There are some QRS complexes that are very narrow, some QRS complexes that are very wide, and then there's variations in changing morphologies all the way across. You'll notice that the morphologies, the width, and the height of the QRS complexes is just randomly changing. And that's a very important characteristic of atrial fibrillation with WPW. The other thing that you get with AFib WPW is that in some places the rate can get incredibly fast. And that's because the accessory pathway is like greased lightning. It can conduct at extremely rapid heart rates. And the result is that in some places you've got rates that are about 250 or 300 beats per minute. Normal bundle branch block, normal AFib just doesn't go that fast. So characteristics again of AFib WPW. It's irregularly irregular, thus AFib. And how do you know there's WPW? An accessory pathway, because the morphologies are going to change, and in some places the rates can approach 250 or 300 beats per minute. if you didn't have that accessory pathway, if all you had was AFib, normal AFib, with all the beats going down the normal his Purkinje system, you would not get rates approaching 250, 300 anywhere on the 12-lead EKG. You'd have rates of 150, maybe 180. But when you see rates that are faster than 200, faster than 250, it means there must be some type of accessory pathway in that AFib type of patient. Now, the other question that comes up, people oftentimes say, well, when you look at this, how do you know this isn't polymorphic VTAC or torsade? Well, from a practical standpoint, it probably doesn't matter, because if a person has torsade, they'll be unstable and you're going to shock them. And if you shock the torsade patient, that's perfect. If you shock this patient, that's going to work as well. So if you ever are not sure whether you're looking at AFib, WPW, or you're looking at torsade, and you just want to shock the patient, good for you. You're going to end up treating the patient properly. But if you really want to know how to tell the difference between AFib, WPW versus polymorphic VTAC and torsade, AFib WPW, you'll notice the axis doesn't change. I usually look at lead 1 in AVF for the axis, and the axis in this particular case is not changing. If you add a patient with torsade or polymorphic VTAC, you're going to see the axis is changing as as you march across the EKG strip. And in this particular case, the axis is not changing, and that weighs heavily in favor of AFib with WPW. Okay, let's keep moving forward. Now, this is atrial fibrillation with just a plain old right bundle branch block pattern. There's no accessory pathway here. How do you know? How do you know there's no accessory pathway? Well, two reasons. Number one, the morphologies are pretty much all the same. And secondly, nowhere are you approaching anywhere on this 12-lead EKG rates of 250 or 300 beats per minute. So there's no accessory pathway. This patient has a wide QRS simply due to a right bundle. And you don't have to worry about accessory pathway because the morphologies are not changing and because nowhere are you getting rates really, really fast. Here's AFib with the left bundle. There's no accessory pathway here. How do you know there's no accessory pathway? Well, once again, the morphologies are all the same and nowhere are you approaching rates of 250 or 300 beats per minute. Take a look back up here, all right? The morphologies are changing, and in some places rates approaching 250, 300 beats per minute. And that means that there must be an accessory pathway here. So if you ever wonder, how do you know that this is not AFib with a right bundle or AFib with the left bundle? Well, very simple. If this were simply AFib with the bundle branch block pattern, and that's why it's wide, then what you would see is you would see morphologies that all look the same, and you would see rates that are no faster than 200 beats per minute. But when the rates get faster and the morphologies are changing, you've got to assume that there's an accessory pathway. Okay, now how do you treat this patient? Well, let me take you to another case. This was sent from Oman by Dr. Faisal Sawafi. He sent this. This is a 30-year-old male who presents with palpitations. This is AFib with WPW once again. How do you know? Well, the morphologies are changing, and in some places the rates are approaching 250, 300 beats per minute. So therefore, there's got to be an accessory pathway going on here. All right, so hopefully everybody's on board with that. It's irregularly regular, so it's AFib. The morphologies are changing, and the rates get extremely fast. So AFib with WPW. Now, in this particular case, Dr. Sawafi decided to treat the patient with amiodarone. And take a look at what happens. The patient ends up converting back to sinus rhythm with amiodarone. Patient's back in sinus rhythm, and now you see the very nice delta waves and the short PR intervals. And so this is your classic sinus rhythm with WPW. But on this videocast before, many times I've said that I prefer that people do not use amiodarone. Here's why. Here's another AFib with WPW. It's irregularly regular, the morphologies are changing, and in some places rates approaching 250 or 300 beats per minute. This patient got amiodarone and went right into ventricular fibrillation. And the patient nearly died. They were able to shock the patient out of it. But this is something that amiodarone has been very well known to do. In fact, there's multiple publications. This is just a handful, and who knows how many times this happened that people didn't run out and publish their case, right? So AFib is known to potentially produce, amiodarone is known to potentially produce decompensation in patients with AFib and WPW. Why is that? why is it that amiodarone can be deadly with AFib WPW? Well, very simple. Here's why. Here's your AFib WPW picture that I showed you a little while ago, and I mentioned some beats are coming down the normal pathway, some beats are coming down the accessory pathway. A lot of beats actually get squashed right there in the AV node. If you use an AV nodal blocker and you essentially take out the AV node, all of those beats are just going to head down the accessory pathway. And so now, instead of a rate of 200, 250, 300, you now have a rate of 400, 500, 600 that are all heading down the accessory pathway, which is all too happy to conduct everything it sees. So instead of a rate of 250 or 300, you now suddenly have a rate of 400 or 500 or 600 because you block the AV node, sending all the impulses down the accessory pathway. That's called ventricular fibrillation. That's called death. Okay, so be very careful. You are not supposed to give any AV nodal blockers when you have AFib WPW. What are examples of AV nodal blockers? Adenosine is a potent AV nodal blocker, and even though it's short-acting, it produces a quick kill. Calcium channel blockers, beta blockers, DIG. DIG is very slow-acting, and the reports say that DIG produces a very slow kill. All right, so any AV nodal blockers. Well, it turns out that when you look at the pharmacology of amiodarone, amiodarone is actually a class 1, 2, 3, and 4 antiarrhythmic. Remember, class 3, that's potassium channel stuff. That's okay. Class 1, sodium channel. But class 2 is beta blocker. Class 4, calcium channel blocker. And a lot of people don't realize it, but amiodarone is part beta blocker and part calcium channel blocker. Amiodarone, therefore, is an AV nodal blocker, and as far as I'm concerned, should be contraindicated in patients with AFib and WPW. Now, if you're lucky, as Dr. Sawafi and many others are, if you get lucky, what's going to happen is that your patient will get amiodarone, and the class 1 or class 3 effects may predominate, and it will work. But if you're not lucky, and the class 2 and class 4 effects predominate, and you get AV nodal blockade, that will produce VFib and then a flat line. You kill the patient. So be very careful about ever using amiodarone in AFib WPW. What I would prefer to do is exactly what Dr. Neal ended up doing, because he knew about this. He just sedated the patient and lit him up, shocked him at 150 joules, and voila. Perfect scenario. The patient went right back to sinus rhythm, life saved. There's your nice short PR interval and your delta waves, and the patient's back to sinus rhythm, and I assume got admitted and ablated afterwards. Okay, now this is a little bit of a controversial thing. Some people still publish that you can use amiodarone, but again, as far as I'm concerned, all the literature that's been published seems to indicate that amiodarone can really be potentially deadly. I haven't come across good studies or any studies saying that IV amiodarone is safe. I've only come across studies in the literature saying that IV amiodarone can be harmful. And I showed you one case, and there's many, many other cases out there of IV amiodarone in AFib WPW. Patients end up doing badly, decompensating, VFib, sometimes even dying. So as far as I'm concerned, we know that you stay away from all the AV nodal blockers. You should remember that amiodarone is part beta blocker, part calcium channel blocker. In other words, amiodarone is an AV nodal blocker. And if you're lucky, the class 1 and 3 effects predominate, the patient will do okay. But if you're not lucky, class 2 and class 4, AV nodal blockade predominates, patient's dead. All right. So once again, AFib WPW. How do you know you're looking at AFib WPW? Well, it's irregularly irregular, thus AFib, and the complexes will vary in shape and width and be extremely rapid. These two factors tell you you're looking at an accessory pathway. And when you see that, you know what? I think the safest drug to use is procainamide, and if you don't have procainamide, do exactly what Dr. Neal did. Just sedate the patient and shock the patient. And that's a very fast, simple, and reliable way of converting these patients back to sinus rhythm. All right? So, AFib WPW, a lot of fun, a lot of danger if you do it wrong. Okay? My thanks to Dr. Sawafi and also Dr. Neal for sharing their cases with us. I hope that was helpful, and I look forward to talking to all of you next week. Bye for now.